Introduction. Diabetes mellitus and glaucoma are two of the most common chronic diseases affecting the eye. At first glance, they can seem quite different. Diabetic retinopathy develops primarily because high blood sugar in diabetes damages the tiny retinal blood vessels. In contrast, primary open-angle glaucoma, POAG, the most common form of glaucoma, traditionally is thought to arise from increased pressure inside the eye, intraocular pressure, or IOP, that slowly injures the optic nerve. Thus, it is natural to ask, does diabetes cause glaucoma in the same clear-cut way it causes diabetic retinopathy? The answer is nuanced. Diabetes does not directly cause POAG in the linear, one-to-one way that high blood sugar causes retinal blood vessel damage. Instead, accumulating evidence shows that diabetes significantly increases the risk of developing glaucoma by creating a complex biochemical and vascular environment in the eye that makes glaucoma more likely to start, worsen faster, and respond less well to treatment. Specifically, large epidemiologic studies and meta-analyses have found that people with diabetes carry roughly a 36 to 50% higher risk of developing POAG than people without diabetes, after accounting for factors like age and race. However, this statistical association does not mean that every diabetic patient will get glaucoma, or that diabetes directly injures the optic nerve in the same way it injures blood vessels. Instead, researchers believe multiple overlapping mechanisms are at work. These range from the toxic effects of chronic high blood sugar on the drainage angles of the eye, to insulin-related changes in fluid production, to diabetic nerve damage and inflammation, and to decreased blood supply to the optic nerve. Moreover, diabetes is an undeniable cause of a very severe secondary glaucoma called neovascular glaucoma, which arises from advanced diabetic retinal disease and accounts for a disproportionate share of tragic vision loss in diabetics. In this article, we will explore in detail how diabetes influences glaucoma risk and progression. We will begin by reviewing the evidence that diabetes and POAG are linked, then dissect the multiple mechanical and cellular mechanisms by which high blood sugar and related metabolic changes damage the eye's outflow pathways, optic nerve, and support structures. We will also cover neovascular glaucoma, walking through the classic cascade from advanced diabetic retinopathy to painful severe glaucoma. We will critically examine the epidemiology, why some studies find strong associations and others do not, and how diabetes is entwined with many other risk factors. We will discuss real-world challenges when both diseases coexist. For example, how diabetic treatments can mimic or mask glaucoma and vice versa. We will then look at treatment considerations for glaucoma in diabetics, from medication interactions to surgical outcomes. Finally, we will survey emerging research at the frontiers, how diabetic neurodegeneration, gut microbiome changes, diabetes medications like metformin and GLP-1 agonists, and genetics may link the two diseases. Throughout, we aim to translate technical insights into practical, patient-friendly guidance. Our goal is to give patients and their doctors an actionable framework, how to screen, prevent, and manage glaucoma in the context of diabetes, and how aggressive control of diabetes and systemic factors can materially protect the eyes. Bottom line, diabetes by itself is not so much a direct cause of typical glaucoma as it is a modifier of risk. Diabetes creates a long-term environment of metabolic stress, vascular damage, and inflammation in the eye that makes all forms of glaucoma more dangerous. But the risk it poses can be managed. With vigilant eye screening, careful treatment, and tight diabetes control, a patient with diabetes can dramatically lower the odds that glaucoma will steal vision. Diabetes and glaucoma, elevated risk, not a simple cause. For decades, ophthalmologists have observed that patients with diabetes seem to develop glaucoma more often than those without diabetes. Large studies and reviews have quantified this effect. A 2017 meta-analysis reviewing several prospective studies around the world found that having diabetes increased the risk of developing open-angle glaucoma by about 36%, odds ratio 1.36. Another systematic review combined many studies and reported a similar pooled relative risk of 1.40, 40% higher. In practical terms, means that if the chance of developing glaucoma in a given time frame is, say, about 2% for people without diabetes, it might be roughly 2.8% for those with diabetes, 36% higher, or even more, as high as 3%, 50% higher. These increased odds hold true even after adjusting for age, sex, race, and other common factors. In other words, diabetes adds to the baseline risk of glaucoma. However, it is equally important to emphasize what these numbers mean in plain language. Not every person with diabetes will get glaucoma, and many people without diabetes do get glaucoma. Diabetes is a risk factor for glaucoma, not a definitive cause in each case. The presence of diabetes creates conditions in the eye that make glaucoma more likely, but it works through multiple indirect pathways. This is quite different from diabetic retinopathy, where the disease process is driven in a clear chain: high blood sugar, biochemical pathway activation in retinal vessels, vessel damage and leakage. For glaucoma, the pathways are multiple and overlapping, as we will detail below, and there is still debate over exactly which mechanisms matter most. In addition to open-angle glaucoma, diabetes is also strongly and directly tied to neovascular glaucoma, NVG. Neovascular glaucoma is a secondary glaucoma, meaning it arises from another eye condition that is one of the most feared complications of diabetic retinopathy. Studies consistently show that a large fraction of NVG cases are caused by uncontrolled diabetes and proliferative diabetic retinopathy. Indeed, one review noted that diabetes accounts for about 30% of neovascular glaucoma cases worldwide. NVG is induced by severe retinal ischemia and VEF release, more on this later, and it tends to be extremely aggressive and painful. We will cover NVG in its own section because it irrefutably stems from diabetes. To summarize this section, diabetes does not simply cause primary open-angle glaucoma in the same straightforward way it causes diabetic retinopathy. Instead, diabetes raises the probability of developing glaucoma through a complex web of insults to the eye. Statistically, diabetic patients face roughly a 36 to 50% higher risk of POAG than similar non-diabetics. And diabetes unequivocally causes neovascular glaucoma when end-stage retinal disease unleashes abnormal blood vessels in the eye. In the widely used phrase, diabetes doesn't so much cause glaucoma as it creates an environment in which glaucoma is more likely to start and worsen. Mechanisms: how diabetes makes glaucoma more likely. Diabetes affects the eyes in many ways beyond the obvious damage to retinal vessels. When it comes to glaucoma, ophthalmologists have proposed multiple intertwined mechanisms by which chronic high blood sugar, hyperglycemia, and metabolic dysregulation could raise intraocular pressure or make the optic nerve hurt more easily. These include advanced glycation end products, AGEs, in the drainage angle. In diabetes, glucose can chemically bind to proteins without enzymes, forming AGEs. AGEs accumulate in many tissues, for example, thickening blood vessel walls. In the eye, AGEs build up in the trabecular meshwork, the spongy tissue that drains fluid out of the eye. Laboratory studies show that exposing human trabecular cells to AGEs makes them stressed, less viable, and pro-inflammatory. This could thicken or stiffen the extracellular matrix, collagen and glycosaminoglycans, in the meshwork, similar to how basement membranes thicken in diabetic small vessels. The net result is higher outflow resistance. In short, AGEs are thought to clog up and stiffen the drainage channels, helping to raise IOP over time in diabetics. Insulin and growth factor effects on fluid dynamics. Insulin and insulin-like growth factors, IGFs, regulate many cells' activity. The ciliary body epithelium, which produces aqueous humor, the eye's fluid, has insulin IGF receptors. In insulin resistance, circulating insulin levels are chronically high. Some researchers theorize that this excess insulin stimulation might increase aqueous production. The idea is that insulin could promote fluid secretion via its receptor on the ciliary epithelium, though direct evidence in humans is still under study. Increased fluid inflow, coupled with reduced outflow as above, would push IOP higher. Diabetic autonomic neuropathy involving the eye. Diabetes can damage small nerve fibers, autonomic neuropathy, including those supplying the eye's drainage and fluid-regulating tissues. The ciliary muscle and trabecular meshwork receive autonomic innervation, parasympathetic and sympathetic branches. If diabetes impairs this neural signaling, the fine-tuned control of fluid outflow could be disrupted. For example, a healthy parasympathetic tone helps trabecular relaxation and outflow. Loss of that tone could make the meshwork sluggish. Diabetic neuropathy in the ciliary ganglion or other ocular nerves might therefore tilt the balance toward higher IOP. This mechanism is plausible but harder to quantify or directly cite. It is analogous to diabetic gastroparesis or orthostatic hypotension, just in the eye. Oxidative stress damaging outflow cells and nerves. Diabetes unleashes a tsunami of oxidative stress in tissues throughout the body. High blood sugar drives several interlocking biochemical pathways: the polyol pathway, glucose converted to sorbitol, protein kinase C overactivity, hexosamine pathway flux, and mitochondrial superoxide generation. All these lead to excess reactive oxygen species, ROS. ROS damage cellular proteins, DNA, and membranes. In the eye, oxidative stress can injure the trabecular meshwork, endothelial cells, making outflow dysfunction worse, and also harm the retinal ganglion cells, the neurons damaged by glaucoma. Remarkably, it can even affect optic nerve head astrocytes. These astrocytes normally help support the nerve fibers. Oxidative injury can make them produce inflammatory signals. So oxidative stress from diabetes may simultaneously impair drainage and weaken the optic nerve. Each alone, high IOP or nerve vulnerability, might be compensated, but combined, they can accelerate glaucoma damage. Diabetic microvascular insufficiency at the optic nerve head. Diabetic microangiopathy is famous in the retina and kidneys, but it also affects the tiny vessels supplying the optic nerve. The optic nerve head's blood comes from the short posterior ciliary arteries. Diabetes causes narrowing and basement membrane thickening in such small arteries. This can reduce the perfused area of the nerve head. A healthy optic nerve can tolerate moderate IOP rises because it has adequate blood flow reserve. But if diabetes has already compromised that blood supply, even a modest pressure increase can tip the balance into ischemia of the nerve fibers. In fact, some population studies suggest diabetic patients show glaucomatous damage at lower IOPs than non-diabetics. This implies the diabetic optic nerve may run out of oxygen earlier when pressure rises. Chronic neuroinflammation. In diabetes, not only vessels and nerves, but immune cells are perturbed. The retina harbors microglia, immune sentinels, and astrocytes. Chronic hyperglycemia tends to push these glial cells into an activated, pro-inflammatory state. For example, diabetic retina releases higher levels of cytokines like TNF-α, IL-1 beta, and IL-6. These factors create a hostile microenvironment for neurons. In a diabetic eye that also has elevated IOP, you get a two-hit situation. Pressure injures the retinal ganglion cells mechanically, while inflammation makes them less able to withstand stress. Over time, this accelerates retinal ganglion cell death. Each of these mechanisms is under active research. The bottom line is that chronic hyperglycemia acts like pus in multiple gears of the glaucoma machine, clogging the drain, AGs in the meshwork, jamming up fluid control, neuropathy, insulin effects, inflaming tissues, oxidative stress, microglia, and starving the optic nerve, ischemia. The result is that diabetic eyes may have stiffer drainage angles, higher average IOP, and a more vulnerable optic nerve than otherwise similar eyes. Citations. Research has established some of these mechanisms in detail. For example, cell culture studies show that age-related glycation products increase oxidative stress and cell senescence in trabecular meshwork cells. Reviews of oxidative stress emphasize how ROS damage outflow structures and retinal cells in glaucoma. Studies of diabetic retinas document elevated TNF-α, IL-6, and microglial activation. And genetic physiology studies reveal that diabetic animals lose retinal ganglion cells even before visible retinopathy. All these lines of evidence illustrate the biochemical precision of diabetes' assist to glaucoma. Neovascular glaucoma, diabetes' most devastating gift. While diabetes' contribution to open-angle glaucoma is indirect and multifactorial, one form of glaucoma it does cause very directly is neovascular glaucoma, NVG. NVG is a catastrophic, painful glaucoma that arises when new abnormal blood vessels grow on the iris and over the drainage angle, physically blocking outflow and causing runaway pressure elevation. Diabetic retinopathy, especially proliferative diabetic retinopathy, PDR, is the single most common cause of NVG worldwide. In the United States and other countries, roughly half of NVG cases are due to diabetes. Diabetic NVG exemplifies how far advanced diabetes can damage the eye. It usually appears only after years of severe diabetic vascular disease, and once it takes hold, it is extremely difficult to control. The cascade usually goes like this. Chronic, poorly controlled diabetes injures the retina's small vessels. Over time, large swaths of the retina become ischemic, oxygen-starved. This commonly manifests first as non-proliferative diabetic retinopathy, NPDR, and then progresses to PDR, where retina veers to form new vessels. The retinal cells respond by massively upregulating vascular endothelial growth factor, VEGF, and other angiogenic factors. These factors can diffuse through the vitreous into the front of the eye. In response, new fragile blood vessels sprout across the iris surface and into the angle, a phenomenon called rubeosus iridis. Initially, these new vessels block the trabecular meshwork somewhat like a mesh. The angle is still open but clogged, open-angle NVG. Pressures can jump sky-high, often 40-60 mmHg or more, because the aqueous fluid cannot drain properly. Even worse, as these new fibrovascular membranes mature, they shrink and scar. They pull the iris up against the cornea at the periphery, causing permanent peripheral anterior synechiae, essentially gluing the angle shut, angle closure NVG. When the angle is closed this way, the glaucoma becomes extremely refractory to treatment. The clinical picture is dire. The eye swells with IOP so high that it causes severe pain, corneal clouding, and rapid optic nerve destruction. Patients often lose all vision and suffer relentless glaucoma pain. Many of these eyes become so painful and blind that the only option left is enucleation, removal of the eye. This is why NVG is often called a terminal complication of diabetic retinopathy. Despite modern therapies, panretinal photocoagulation, laser, and anti-VEGF injections, NVG remains one of the toughest problems. The key is prevention. By the time iris neovascularization is clinically obvious, significant angle damage has often already occurred. Research emphasizes that treating the underlying proliferative retinopathy before NVG sets in is far more effective than trying to fix the glaucoma late. Prompt pan-retinal laser, PRP, to the ischemic retina reduces VEGF drive, and anti-VEGF injections, like bevacizumab or ranibizumab, can rapidly clear new vessels. In contrast, waiting until NVG is advanced often means only partial success with glaucoma surgery or drop therapy. In summary, neovascular glaucoma is the clearest example of diabetes causing glaucoma. The sequence is precise: advanced diabetic retinal ischemia, VEGF-driven iris and angle vessels, rubeosus iridis, membrane formation, open-angle obstruction, progressive synechial closure, massive IOP rise, optic nerve destruction. No other mechanism is needed for NVG. It is a straight-out stretched result of diabetic retinal disease. For patients, this is a sobering reason to control blood sugar and risk factors aggressively, and for retina doctors to treat high-risk diabetic eyes in time. Citations. The pathophysiology of NVG in diabetes is well documented. For instance, Tang et al. 2023 review notes that proliferative diabetic retinopathy, PDR, is one of the leading causes of NVG, and that diabetes accounts for 30% of NVG cases globally. They describe the three stages: rubeosis, open-angle NVG, and synechial closure, and emphasize that NVG pressures can be extremely high with rapid vision loss. Preventive strategies, PRP, anti-VEGF, are thus critical. Epidemiology, sorting out the data. The picture from population studies is consistent but has nuances. Meta-analyses combining many studies give odds ratios, 1.3 to 1.5, that diabetes is associated with higher POAG risk. But individual studies vary. Landmark cohort studies like the Blue Mountains Eye Study, Australia, and the Rotterdam Study, Netherlands, did find a significant link between diabetes and open-angle glaucoma. For example, the Rotterdam study reported an elevated prevalence of glaucoma in diabetics, though exact numbers vary by subgroup. On the other hand, some studies such as the Barbados Eye Study, a mainly Afro-Caribbean population, and the Melbourne Visual Impairment Project, Australia, found a weaker or non-significant relationship between diabetes and open-angle glaucoma. Why the discrepancy? Several methodological issues cloud the waters. Detection bias. People with diabetes generally see eye doctors more often for retinopathy screening and cataract checks. This means glaucoma in diabetics is more likely to be spotted than glaucoma in otherwise healthy people who might skip routine eye exams. So, part of the observed higher glaucoma risk could simply be because doctors are looking more closely at diabetics. If we screened everyone equally, the gap might shrink. Confounding factors. Diabetes rarely comes alone. It is part of a cluster of metabolic problems. Obesity, high blood pressure, high cholesterol, and even obstructive sleep apnea often occur in diabetic patients. Many of these factors, especially hypertension and sleep apnea, may themselves influence IOP or optic nerve health. Untangling whether diabetes per se is to blame versus the web of related health issues is methodologically hard. Many studies attempt to adjust for these confounders, but residual bias remains possible. Genetic versus environmental links. People often ask if the diabetes glaucoma link might be genetic. Genome-wide studies have begun to explore this. A recent Mendelian randomization study, which uses genetic markers as proxies for lifelong high blood sugar, found that genetically predicted type 2 diabetes increased glaucoma risk, hazard ratio TWI 1.11. This gives some evidence of a causal effect of diabetes itself. Interestingly, the same study also suggested higher long-term glucose, HbA1c, and blood pressure causally raise glaucoma risk. In contrast, body mass index alone did not show a direct effect. These genetic studies support the idea that metabolic factors do indeed contribute causally to glaucoma, beyond mere association. Dose response and sub-analysis. Some analyses find that the worse the diabetes, the higher the glaucoma risk. For example, long-standing diabetes and presence of diabetic retinopathy in a patient are often associated with greater glaucoma risk than well-controlled or short-duration diabetes. One large Danish case control study found that patients with diabetes had about 1.8 times the odds of developing medically treated glaucoma than non-diabetics. However, intriguingly, this study did not find a difference based on HbA1c level or years of diabetes. Glaucoma risk was elevated in diabetics of all durations. Other data hint that each 1% rise in HbA1c might slightly increase glaucoma risk, but the evidence is not fully settled. We do know that every study consistently shows diabetic retinopathy itself predicts glaucoma. Even if a diabetic without retinopathy has only modestly increased risk, the onset of any retinopathy signals microvascular damage that also affects optic nerve perfusion, raising glaucoma vulnerability. In practical terms, it is safest to assume that diabetes does raise glaucoma risk, regardless of the contradictions in some studies. A meta-analysis in 2014 concluded that individuals with diabetes have a significantly higher risk of POAG. The exact size of the effect can depend on how the study is done, but the consensus is a meaningful 30 to 50% increase in risk. Importantly, confounders like obesity or blood pressure may amplify this risk. One MR study suggests that blood pressure and glucose levels are individually additive causes of glaucoma. Citations: the increased risk is documented in meta-analyses. Mendelian randomization in UK Biobank and other cohorts found that genetic predisposition to type 2 diabetes and higher HbA1c causally raised glaucoma risk. The Danish population study noted a nearly twofold risk of glaucoma surgery in diabetics, though it did not show a dose response with glycemic control. Overall, the pattern across studies, plus the mechanistic plausibility above, supports diabetes as an independent risk factor for glaucoma. Diagnostic and treatment challenges. When diabetes and glaucoma coexist. When a patient has both diabetes and glaucoma, the two diseases can masquerade as each other and complicate diagnosis and management. Overlapping retinal nerve damage. Both diabetic retinopathy and glaucoma eventually damage retinal nerve fiber layers. Optical coherence tomography, OCT, of the retina may show thinning of nerve fiber layers in glaucoma, but advanced diabetic retinopathy can cause similar nerve loss. This overlap makes it hard to tell whether visual field loss or OCT changes are due to diabetes, glaucoma, or both. Careful pattern recognition is needed. For example, glaucoma often causes focal arcuate field defects, while retinopathy causes more patchy loss. Still, the coexistence can lead to uncertainty. Laser photocoagulation fields. Patients with proliferative diabetic retinopathy often receive panretinal laser, PRP, to prevent bleeding. PRP deliberately creates thousands of laser burns in the peripheral retina. Those burns create visual field holes that can look very much like glaucoma field defects. In other words, a visual field test in a lasered eye may be left shifted because of the treatments, not because the optic nerve is losing fibers. This makes interpreting glaucoma fields in a lasered diabetic eye tricky. Is a defect new glaucoma damage, or just the effect of old laser scars? Longitudinal comparison and careful attention to the pattern of defects and PRP maps is essential. Injections and systemic meds affecting IOP. Diabetes often requires treatments intravitreal injections, corticosteroids, that can influence eye pressure. For example, anti-VEGF injections used to treat diabetic macular edema or retinopathy can cause a transient spike in IOP right after the shot. Rarely, repeated injections can lead to a sustained pressure rise or rush a patient already predisposed into ocular hypertension. Similarly, intravitreal corticosteroids, like triamcinolone or dexamethasone implants for macular edema, are well known to cause significant IOP elevations in susceptible eyes. Diabetic patients may even be more steroid sensitive in some cases. Glaucoma specialists must watch intraocular pressure carefully after each injection or steroid treatment. Misidentifying optic nerve swelling versus glaucoma. Diabetes itself can rarely cause a benign optic disc swelling called diabetic papillopathy, typically in younger diabetics with type 1. Papillopathy causes mild optic disc edema and visual blur that usually recovers, but it can look on exam like normal pressure glaucoma, with disc changes, or raise suspicion for other neuropathies. Conversely, early glaucoma can sometimes look like a mild disc edema. Without the classic high IOP sign, and in a diabetic patient, physicians might hesitate on the diagnosis. In such cases, fluorescein angiography or imaging over time can help differentiate the two conditions. Medication interactions and side effects. Treating glaucoma in diabetics carries special caution. Classic glaucoma drops, like beta blockers, carry systemic risk. Timolol eye drops can be absorbed and mask hypoglycemia symptoms or impair glucose recovery. This can be dangerous for a patient on insulin or sulfonylureas. Prostaglandin analog drops, such as latanoprost, bimatoprost, might potentially worsen diabetic macular edema by perturbing the compromised blood-retinal barrier, although large studies have not definitively shown a big problem. Still, doctors often monitor macular thickness if adding PGAs. Alpha agonist drops, brimonidine, reduce IOP partly by vasoconstriction. In a diabetic with marginal optic nerve perfusion, this could conceivably be unfavorable, though data is limited. In short, every glaucoma medication's systemic and ocular side effects must be weighed carefully in a diabetic patient. Surgical outcomes. Diabetes can affect glaucoma surgery too. For trabeculectomy filtering surgery, diabetics, even without visible retinopathy, often show worse long-term success. For example, one study found about 58% success at 5 years in diabetics versus 69% in non-diabetics. The reason likely involves both thickened conjunctival tissues, AGEs, and fibroblast changes, and persistent inflammation, leading to scarring of the bleb. For glaucoma drainage devices, tube shunts, diabetics do about as well as others in lowering pressure, but have extra concerns. For NVG patients, iris neovascular membranes often still form around the tube's plate, and there can be more chance of peripheral anterior synechiae binding the tube. Surgeons may use additional anti-scarring measures or plan combined retina glaucoma procedures in such cases. Importance of systemic control. Perhaps most importantly, everything above can be influenced by how well the diabetes is managed. While high blood sugar is not the only factor raising glaucoma risk, better glycemic control does protect blood vessels and nerves. Some studies suggest that tight control of blood sugar, blood pressure, and lipids reduces rates of microvascular complications and likely helps glaucoma indirectly. This underscores that managing a diabetic patient's systemic health is also part of glaucoma care in these cases. In summary, when diabetes and glaucoma coexist, the path to clear diagnosis and safe treatment is narrower. Overlapping signs, treatment overlaps, and side effect risks mean that eye doctors must collaborate closely with the patient's primary doctors and endocrinologists. Regular communication and documentation, e.g., noting PRP treatment on glaucoma fields, or warning a patient taking timolol about hypoglycemia, are essential to avoid missteps. The good news is that with awareness of these pitfalls, doctors can tailor the approach. For instance, choosing glaucoma drops that don't spike sugars, scheduling IOP checks after injections, and relying on imaging, OCT, angiography for more objective monitoring. Citations. Some of these issues are well recognized in clinical literature and guidelines. For example, the known fact that ocular timolol can precipitate or mask hypoglycemia in diabetics is documented in case reports, e.g., timolol eye drops leading to severe hypoglycemia. Anti-VEGF for DME has been studied. Diabetic retinopathy clinical research network trials noted that multiple ranibizumab injections carried a risk of sustained IOP elevation. Nearly 9% of eyes needed pressure-lowering therapy over 3 years. And experts routinely note that PRP fields can mimic glaucoma fields, and steroids can elevate IOP. The key message clinically is vigilance. The presence of one disease does not exclude, but rather heightens the need to watch for the other. Emerging connections: neurodegeneration, microbiome, and medications. Recent research is uncovering deeper links between diabetes and glaucoma that go beyond classic vascular and pressure factors. These include shared neurodegenerative pathways, the gut-eye axis, and even the effects of diabetic drugs on glaucoma risk. Retinal neurodegeneration bridges. Traditionally, diabetes complications were thought of as purely vascular, but now we know diabetes causes early nerve cell damage in the retina too. Studies find that even before any visible retinopathy, diabetics can have thinning of the inner retina and loss of ganglion cells. This diabetic retinal neurodegeneration shares a lot with glaucoma's nerve loss. Some experts propose that diabetic ganglion cell stress and apoptosis might be the earliest common ground in a spectrum of disease. In other words, diabetes might set the stage for glaucoma by priming retinal nerves to die. Animal models also show that diabetic mice plus induced eye pressure have worse nerve loss than either condition alone. These findings suggest there are shared pathways of oxidative stress and cell apoptosis in both diseases. In the future, doctors may think of diabetic eyes as having an underlying nerve vulnerability even when pressures seem normal. Gut microbiome and the gut-retina axis. The idea that gut bacteria can influence the eyes is new, but intrigued. Both diabetes and glaucoma have been linked to shifts in gut microbiota and systemic inflammation. Some research has found that glaucoma patients have different gut bacterial profiles. For example, a high Firmicutes bacteroides ratio compared to healthy controls. Similarly, people with metabolic syndrome and diabetes often have dysbiosis. The hypothesis is that an unhealthy gut microbiome could drive chronic inflammation and oxidative stress throughout the body, including the retina and optic nerve. This gut-eye axis theory is in early stages, but it offers a potential unifying explanation. Systemic metabolic health, reflected in the microbiome, affects both diabetic changes and glaucomatous susceptibility. Effects of diabetic medications. Interestingly, some drugs used for diabetes appear to influence glaucoma risk, likely through non-glucose mechanisms. Metformin. This common diabetes drug, an AMPK activator, has shown promise in retinal protection. One large cohort study found that diabetics taking the equivalent of at least 1,100 grams metformin over 2 years had about a 25% lower risk of developing open-angle glaucoma than those on no metformin. The more metformin they used, the lower the risk. Metformin is thought to reduce fibrosis and inflammation, possibly limiting trabecular meshwork stiffening and protecting retinal ganglion cells. While these data are observational and not yet conclusive, they support the idea that metformin's caloric restriction mimetic effects might slow eye aging. GLP-1 receptor agonists. Newer diabetes drugs like liraglutide and semaglutide, which mimic incretin hormones, have surprising neuroprotective effects. Preclinical glaucoma models show GLP-1 agonists can preserve retinal ganglion cells and reduce inflammation in the optic nerve. A recent review compiled human data suggesting that GLP-1 RA users, even with obesity, tend to have a lower incidence and progression of glaucoma than comparable patients on other treatments. These drugs lower systemic inflammation, and some may improve ocular blood flow. While not yet standard glaucoma therapy, this is a hot area of research, and ophthalmologists will be watching as more data emerge. Thiazolidinediones, TZDs, drugs like pioglitazone activate PPAR-GONG. They reduce insulin resistance, but have been linked to fluid retention. Some studies hinted at a slightly higher risk of macular edema or eye fluid problems with TZDs, but the evidence is mixed. There is even some suggestion of increased glaucoma risk with long-term TZD use, though mechanisms are unclear. It's possible that increased vascular permeability or weight gain play a role here. Genetic overlaps. Finally, gene studies, genome-wide association studies, GWAS, are beginning to find genetic loci that influence both diabetes and glaucoma risk. One recent analysis identified genetic regions that might be involved in both type 2 diabetes and POAG. Such shared genetic architecture hints that beyond the environment, there are inherited pathways, perhaps related to lipid metabolism or inflammation, that tie the diseases together. In the future, it may be possible to use combined genetic risk scores to identify patients at very high risk for both conditions. Overall, these emerging insights paint a picture of diabetes and glaucoma as intersecting neurometabolic diseases. They invite us to think of diabetic eye care not only as sugar management, but also as neuroprotection and anti-inflammation. They also suggest new therapeutic angles. For example, could cardiometabolic drugs like GLP-1 agonists become part of a glaucoma prevention strategy? Citations. The idea of early retinal nerve damage in diabetes comes from histology and imaging studies. The gut-retina connection is still speculative, but eye disease reviews note that gut microbe signals are essential to retinal health, and that microbiome changes have been observed in glaucoma. Diabetic drug effects on glaucoma have been studied. Lin et al. Found significantly reduced glaucoma risk with high-dose metformin, and multiple analyses have associated GLP-1 RA therapy with lower glaucoma incidence. These findings are early, but suggest exciting crosstalk between diabetes treatments and eye health. Clinical recommendations for patients and doctors. Given everything above, what should diabetic patients and their doctors do to protect vision? Here are actionable guidelines drawn from ophthalmology and endocrinology best practices. Regular glaucoma screening for all diabetics. Even at the time of diabetes diagnosis, patients should have a comprehensive eye exam that includes not only a retinopathy check, but also intraocular pressure measurement, optic nerve evaluation, and ideally OCT imaging of the nerve fiber layer. Gonioscopy, looking directly at the angle, should be done at least once because angle abnormalities or early neovascular changes can be subtle. Then exams should repeat at least annually, or more often if any risk factors or early signs are present. This schedule is recommended regardless of retinopathy. Diabetes itself raises glaucoma risk, so an eye with no visible retinal lesions can still have early glaucoma. For comparison, diabetics often do yearly retinal exams. We say make those full glaucoma exams at the same visits. Strict systemic control. Encourage aggressive management of blood sugar, HbA1c, blood pressure, and cholesterol. Good glycemic control is known to reduce microvascular damage in the retina and elsewhere. Even if diabetes does not cause glaucoma directly, well-controlled diabetes means less cumulative toxicity to eye tissues. Similarly, controlling hypertension and sleep apnea supports optic nerve health. Patients should be told that optimizing diabetes is effectively an ocular protective factor. Watch for red flags. There are certain signs that should prompt urgent glaucoma evaluation in a diabetic patient. Iris or angle neovascularization, rubeosis. Any new vessels on the iris or in the drainage angle, seen on slit lamp exam or gonioscopy, could herald neovascular glaucoma and need immediate retina glaucoma treatment. Asymmetric IOP. If one eye's pressure is much higher than the other, especially if the pressure in one eye is borderline high, investigate more thoroughly for secondary contributors. Diabetes can sometimes cause higher pressures asymmetrically, e.g. from prior injections or uneven drainage impairment. New visual field complaints. Any unexplained blurring or loss of peripheral vision in a diabetic should not be assumed to be just diabetic macular or field loss. Visual field testing should be done to check for glaucomatous defects. Optic disc hemorrhages or neuroretinal rim changes, small flame-shaped hemorrhages, disc hemorrhages on the optic nerve edge are classic glaucoma signs. If seen, even in a diabetic where flames are also seen in retinopathy, evaluate the nerve carefully for glaucoma. Unexplained increase in eye pressure after injections or surgery. If an eye's pressure shoots up after retina treatments or surgery, consider glaucoma-type damage. Acute spikes after anti-VEGF or corticosteroids can persist. Team-based care. Patients with diabetes and any eye issues benefit from coordinated care. Endocrinologists should remind patients to get eye checks, and ophthalmologists should communicate retinal findings back to the internist. If a retina specialist is treating proliferative retinopathy, they should liaise with glaucoma colleagues if any concerning signs, like partial synechia or high pressures, emerge. Conversely, if an older patient is diagnosed with normal tension glaucoma, the doctor might recommend checking for diabetes or metabolic syndrome, since these can influence progression. In short, treat the patient, not just the eye. Modern healthcare often fragments care, but diabetic glaucoma demands bridging specialties. Education and empowerment. Patients should understand the intersection of their conditions. For example, a diabetic who knows that punctual drop use not only helps with sugar, but also saves the optic nerve, is more likely to stick to both treatments. They should be taught the symptoms of acute glaucoma, eye pain, nausea, rainbow halos around lights, so they can seek care if NVG starts. They should also know that vision loss from glaucoma is preventable early on, emphasizing that routine exams are critical even if they feel fine. By following a proactive plan, tight diabetes control, regular eye exams with glaucoma-specific tests, and fast action on warning signs, the vast majority of glaucoma-related vision loss in diabetics can be avoided. The statistics of elevated risk are not destiny. With care, a well-managed diabetic patient who sees their ophthalmologist regularly may actually have a lower lifetime chance of glaucoma blindness than one who does not, despite the underlying risk. Conclusion. In summary, the relationship between diabetes and glaucoma is complex. Diabetes does not simply cause primary open-angle glaucoma. In the straightforward, one-pathway manner, it causes diabetic retinopathy. Instead, it sets the stage for glaucoma through multiple parallel mechanisms: biochemical glycation and stiffening of the drainage tissue, insulin-related increases in fluid production, autonomic nerve damage, widespread oxidative stress, compromised optic nerve blood flow, and chronic inflammation. Large studies and meta-analyses consistently show that diabetics have roughly a 36 to 50% higher risk of developing glaucoma. At the same time, diabetes is an undisputed and major cause of neovascular glaucoma, the most aggressive and vision-threatening form of glaucoma. Clinically, this means that doctors cannot ignore glaucoma risk in diabetic patients. Every diabetic should have that comprehensive glaucoma exam, pressure check, gonioscopy, OCT, visual fields, when diabetes is first diagnosed, and at regular intervals thereafter. Any red flag, iris vessels, pressure asymmetry, new field loss, optic disc hemorrhages, demands urgent glaucoma workup. In management, both patients and providers need to be aware of the interactions: systemic drops that can blunt hypoglycemia signals, injections or steroids that can raise IOP, laser treatments that can mimic field loss, etc. Importantly, the risk from diabetes is modifiable. Aggressive control of blood sugar, blood pressure, and cholesterol can slow diabetic eye disease and likely lower glaucoma progression. Anti-VEGF injections and timely retinal laser can prevent neovascular glaucoma. Choosing glaucoma therapies carefully, for example, using prostaglandins judiciously, avoiding unnecessary steroids, adjusting systemic medications, can mitigate complications. Meanwhile, emerging therapies on the horizon, metformin, GLP-1 analogs, new neuroprotective drugs, offer hope that we may even prevent or slow both diabetic degeneration and glaucomatous damage in tandem. In closing, the key message for patients is optimistic. Having diabetes does not condemn you to glaucoma blindness. It only increases the vigilance needed. By coordinating care between endocrinologists, primary doctors, retina specialists, and glaucoma specialists, and by the patient staying on top of both diabetes and eye health, the elevated risk becomes a manageable one. With modern medicine, a diabetic patient who follows the plan should not end up with irreversible glaucoma vision loss. Ensuring this outcome requires awareness and proactive action, but it is firmly within reach. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.